Well, good morning. Hopefully you can hear me and more importantly see me. Well, actually probably not so important. My name's Louis Forney. I'm President-elect of the International Society of Critical Care Nephrology, which after this webinar, I hope you will all rush off and join on our website. All right. It's a great pleasure for me to introduce our speaker for this Nordia-sponsored webinar. Dr. Chris Kirwan from the London hospital, my local hospital when I was growing up. I've known Chris for some considerable time, even though we've never worked together. He was appointed a consultant in critical care medicine and nephrology at the Royal London in 2012. He probably doesn't want me to remind him of that. And he's honorary senior lecturer at Barts and the London School of Medicine. His main research interests have encompassed lots of facets of acute kidney injury, particularly hepatic drug metabolism and acute kidney injury. Won't want reminding that I was one of his PhD examiners at the College of Anaesthetists some years ago. And that was probably the first time we met, I think. But he's done a lot more on evolving therapies, renal replacement therapies. And today he's going to talk about something that I think is very interesting on dynamic dosing in renal replacement therapy. And we've had the arguments about timing. Some may argue we still haven't answered those questions. But dose, we seem to think we'd conquered where we hadn't really at all. And I'll be interested to hear from Chris as to whether I do it right, according to him, or not. Okay, so with no further ado, I think we've got Gemma on the call as well, who's the face of Nordia. She'll be helping doing some of the technology stuff and helping the questions. There is a chat facility for the questions, and there's also a Q&A box. Don't go near that, go near the chat box, okay? And I think that with that, I think we can kick off.
Morning. Thanks, Louis. I'm going to share my screen and then start the presentation, and then we can sort of get talking. Right. So dynamic dosing for CRRT. I'm going to try and take this from sort of beginning to where we are now. And some of it might be a bit basic, and some of it you may have heard before, and some of the studies and some of the information that we'll go through you'll almost certainly have seen before. But I think the idea is that we're trying to build a bit of a story here, and I'm trying to explain is how we got here, and I'll talk to you about what we do at the Royal London, and you can understand why we've deduced that sort of idea from the information that we've got. So first of all, I've had some unrestricted educational grants and consultancy and speaker area from these firms. Fresenius, if you're listening, I'm very welcome. This is my hospital. It's in the East End of London. For those of you that may not know, we are a major trauma centre, and that's possibly what we're more famous for. But we're also a major renal and transplant centre. We've got 28 level 3 adult critical care beds and another 12 level 2 beds, and also a separate post-operative surgical HDU. And we do about 250 patients for CRRT each year, and about half of those have AKI. So I think we do a lot, and I think that's possibly why we've been able to do some of the things that we have been able to do because of our huge exposure. I think if nothing else, if you come away from this talk and just remember this cartoon, you'll have already made big strides into how you think about renal replacement therapy, critically ill people. This cartoon really drills down the fact that you've either got AKI or CKD, but you could still be acutely metabolically unwell, or you could still require maintenance therapy. And overall, you could also still require fluid removal. And I think these three things, if you continue to think about what am I trying to achieve and what am I trying to get out of my therapy, and you use this little algorithm and you go round it and around it and around it, you'll begin to understand why I think dynamic dosing is a good thing. You need to do this through a protocol. This is the best way to achieve it. And of course, we're going to talk about dose today, but there are lots of other factors like mode, delivery, when, how we keep our circuit patent, perhaps some other things. And although we've got, objectives like, can we improve mortality and many other things, as we'll come to, we also want this to be efficient. We want it to be cost effective. We need to reduce waste. I think that's important. And overall, obviously, it needs to be safe. So suddenly, we've got an awful lot of things to think about. As we're going to talk about dose, I just want to do some real simple basics. Again, some of you may have heard this before, but if not, I think it's really helpful just to remind ourselves how we get to dose and what it means. In the old days, you used to collect some urine, measure the urea concentration in the urine, divide it by the plasma concentration, and this would be your clearance of urea. And this is how we measured renal function. And that was because urea was something that could be measured early on, perhaps before even creatinine in biochemistry labs. So this UV over P is still the basis of how in nephrology we understand renal function. So a simple way to understand clearance or dose in HF or HDF or HD in critically ill patients is to look at urea clearance. And we need to understand that the solute flux, which is how much you can clear across a membrane, is proportional to the filtration rate or the dialysate flow rate, but also dependent on the sieving coefficient of the molecule that you're trying to measure, and that's S. Now, the sieving coefficient is the ratio between the concentration of the solute in the ultrafiltrate in the plasma water, and solutes that freely cross a membrane, like urea, the S is equal or close to 1. So that's really helpful. So that means that the urea clearance is proportional to either the flow rate of the filtrate or the flow rate of the dialysate. And hang on. And because your filtrate rate or your exchange rate or in hemofiltration, your dialysate rate in dialysis is less than the blood flow, then you can assume that every unit of filtrate or dialysate that passes across the blood is saturated by urea because the sieving coefficient is 1. So this is really, really helpful because that means that either your filtrate rate or your dialysate rate is equal to your dose. And that is why everything we talk about is how we get to our dose. This is why we talk about dialysate rates or filtrate rates. It's in this unique position. It's different to if you do intermittent hemodialysis, where the dialysate flow rates are faster than your blood flow rates. So what is the optimal dose of CRRT? So that's sort of the question. And I think the first thing you've got to think about is actually, well, it depends on our outcome measure. And this is where it begins to get a bit more interesting. I'm going to show you some old school trials, and which is the origin of where we got to where we got to. So this was about 2 weeks after I qualified as a doctor. This was published. And this is our first sort of guidance and our first progress into what should we be actually doing in CVVHF. And we decided that we should give 35 mils per kilo. And that's how I started off in intensive care. And another study where we used HDF suggested that there was no difference between standard dose and high dose. But what you'll notice about this study, which was done in America, was that the mortality rates are pretty high. Not very many people survived here, perhaps worse than we would have expected. Then this study came out and said perhaps we should add dialysis to hemofiltration because this will improve survival. And is that a dialysis dose or is this a mode? And I think we got a bit confused by this because I don't think you can, we hadn't decided that dialysis was different or better, or was that dose, or was it the mechanism by which you were doing things? So again, slightly confusing trial, I think, to work out that maybe adding dialysis and doing more would be better. That went even further. We've tried to do very high volume or pretty high volume hemofiltration for people with sepsis, but there was no improvement in 28-day mortality. But this was repeated loads and loads of times. And this is just a handful of papers, from sort of like the mid to late 2010, the early mid 2000s to late 2010s, when we looked a lot at mortality in sepsis and high volume hemofiltration and found an association with vasopressor use, but that didn't lead to mortality. But suddenly you can see here, well, hang on, that's a slightly different outcome measure. And could that potentially be better if we can modify something else? And I think this is the beginning of where this began to spread. In liver disease, if you give people high volume hemofiltration in liver disease, then perhaps you reduce the amount of noradrenaline they have, you improve their mean arterial pressure, perhaps they get better quicker. We know that ammonia clearance has got a fairly linear relationship between dose. So if ammonia clearance is your outcome measure, then definitely you want to give more. We know that in children with very, very high volume hemofiltration, that may have an effect on mortality if they've got acute liver failure. But that's a whole different area, I think. I particularly like this out of China. It's a pretty interesting study early on as they were sort of getting to grips with with doing things in CRRT, suggesting that if you've got severe pancreatitis, if you give more and start earlier, you might improve survival. So that's asking two questions or answering two questions about something completely different. No real explanation why. We know that if we've got rhabdomyolysis, actually our endpoint there is renal damage. We want to remove myoglobin. So doing higher volume exchanges removes myoglobin, and perhaps that has a better outcome for patients with acute kidney injury related to rhabdomyolysis. But we know that high-flux hemodialysis filtration is the gold standard for clearing myoglobin, and also in patients who are critically ill, rhabdomyolysis is actually very multifactorial. It's not just a crush injury, it's sepsis, it's all sorts of other bits and pieces. But again, that's a different outcome measure. So these are the two trials that everybody knows. I'm sure you've all seen before. And this was what is the optimal dose of CRRT to reduce mortality. And this has very much driven our practice coming forward. And the one from Australia, the one from America, and that sat around between 20 and 25 mils per kilo. And that in the late 2008, 2009, changed the way we delivered therapy. So we've gone up and down, we've looked at slightly different outcome measures, and we've settled here with two, I think, reasonable trials. Certainly the one from Australia is pretty good. The one from America, it is use a VA database, and it has lots of different types of modalities of renal replacement therapy, but the sentiment is there. And this is where we've sat for a long time. Okay. But I think a new and more interesting question has come about, and I think this is very topical, and it's, can RRT cause harm? Because that then changes our view again about what our dosing level should be. And I urge you to watch Dr. Emily C's talk. It was the first talk in the series. There's the link, and also plugging the International Society of Critical Care Nephrology. But go and have a look at her talk, because I think this is a really interesting idea too, is that we know that intermittent hemodialysis and that causes dialytrauma, but can CRRT cause trauma, and can it cause damage? And I think Emily begins to go into this quite interestingly, and I've stolen one of her slides to show you later anyway. And if you go back to that Australian trial, finding, which was better, higher or lower dose, then of course things that were harm are definitely a lot more hypophosphatemia and a possible trend towards disequilibrium. The numbers are very small, but feeling that you might possibly get disequilibrium in what's supposed to be a gentle therapy is really quite interesting. So, is there a signal in high dose? Again, I mean, we've gone nearly 10 years ago now. This paper from NDT, the primary outcome of this study was mortality in their systematic review, but the secondary outcome was renal recovery. That's a different outcome measure. And does more dose lead you to have more RRT dependence? And so there was greater RRT dependence in the high intensity group. So actually, is there harm to the kidney by having very, very high doses? And so the questions just get deeper. This is a slide that basically I've just taken from Emily's talk, because she'd done the work and separated this paper out. But again, another systematic review of low versus standard dose therapy in CRRT, and suggestions that mortality may be lower with a lower dose, both in ICU and at 90 days, but also beginning to suggest that if you go too low, then actually that's also bad for you too. There was always going to be a cutoff. We know that if you need CRRT and you don't give any, then that's bad for you, but we didn't know where that marker lies. So this is again beginning that conversation. This is just released this year, and I think it ties on to some of the other work that's been done, and some of those studies show that are mentioned there that lower dose, they've begun to investigate lower dose in renal replacement therapy as a sort of a standard therapy. Here we see that lower dose is not associated with ICU mortality. So that's important. We're beginning to find what the lowest dose is. Other key endpoints were comparable, but we need to do more and more research. And that's the problem with lots of these systematic reviews and meta-analysis. So this paper, and this is a really good infographic from the paper out of AJKD a couple of years ago now. And what this is a single center, but they've kind of found the cutoff at around 13 mils per kilo. And I think that's also really helpful. So that is tied into the meta-analysis that you've just seen, and we're beginning, and we found effectively how low can we go. There's still a few more studies on the way, again looking at very, very low dosage, but where does that kind of leave us? And I think this is something that this is a graphic that I began to build up a few years ago, which I have changed. But where does this all take us? What does this all mean? And when I look at this, you can draw a kind of graph that kind of looks a little bit like this. Okay, I think there is a space where there's clearly some opportunity to have some maintenance dose, and that's clearly in the lower volumes of replacement fluid or dialysis. There are clearly some special circumstances where giving a higher volume is good for the situation that you're looking at. It's good for the outcome measure that you've chosen. And is there a space in the middle for people who are acutely unwell? Not really sure. I think as of now, I used to have that at 20, but now I've had to change it to 13, I think, following that paper from AJKD. And so we've broadened this a little bit. And some of you may argue that actually I've been too generous by allowing 60 and 70 here. But my point is it's special circumstances. And I think that if you're particularly trying to do something, but this is quite a simple sort of 2D graph, and it's probably more complicated than this, but it's a good idea to begin to think about, well, how am I going to do what I need to do that's right for the patient at the time? And actually, someone's already thought about this, and this is a group of people who know an awful lot about renal replacement therapy, and they wrote this as part of the advocacy consensus 10 years ago now, and they said that CRRT dose should be dynamic. It should be adapted to changes occurring in the acute physiology and metabolic profile of critical patients. And precision CRRT dosing should be adapted to target specific solutes. So even 10 years ago, even before, before we've done some of these trials about low dose, the conversation about actually we need to be adaptive, actually you need to look at that graph that I've just showed you and think, well, hang on, there are different phases of illness, and are there different doses associated with different phases of illness, has been talked about. But we haven't really picked up on it, or we haven't really known where to go. I think this is a really helpful graph that comes from that paper, okay? And what it does is it suddenly makes you go, oh my goodness me, this is actually much more complicated than I thought. Or is it? Or do we just have a whole load of variables in our prescription, a whole load of targets to our delivery, a whole set of outcomes that are interchangeable or that change? And what are our quality measures to make sure that we're doing this properly? And then I think the most important thing, oh, my circle has disappeared, is the clinical reassessment. And I think this is the single most important piece of this paper, to remind you that actually this is a process. Things change. You go back and examine your patient. You would never set a fluid balance for a week. You go back, and sometimes you'd do it twice a day, certainly on your morning and evening ward round. Have I got there? Is that appropriate? When you examine patients, what's their neurological change after a head injury? You examine people, you reassess. Why don't we do the same when we're assessing their renal function or assessing the effect of the therapy we're given? Now, I've simplified this a little bit more. And I think what you could look at is you can think, okay, how do I take that really complicated graph? How am I going to manage all of that? And is it really worth it to, well, hang on, these are my prescription targets, perhaps. These are the ones that we're very familiar with, potassium, volume overload, metabolic acidosis. We've got these middle molecules and mediators and toxins, and that's why people thought that high volume hemofiltration may help in severe sepsis and things. And then you've also got prescription controls. So these are the things that we can control now in the modern way that we deliver CRRT. And by changing these and by looking at your prescription targets, can you have a better therapy for a patient? I say go back to this. Go back to my original point, which is you've got this simple cartoon, which is what is the situation and what am I trying to achieve? And that changes and keep going round this circle. So I think the two cartoons fit together quite nicely and just remind you to keep going back and thinking, what am I trying to do here? So what did we do? So we moved from this very old hospital that was built in about 1700 and moved into this nice brand new hospital, which cost us a lot of money because of PFI. That's one thing we did. And then in my vague attempt to ask AI to help me, because I'm useless at this kind of thing, and with the help of my 13-year-old son, I tried to show the evolution of renal replacement therapy through aeroplanes. I don't know why, because I like aeroplanes. But we started with a bit of a wing and a prayer, and intermittent hemodialysis started to be used really in the 50s. In the 1980s, obviously, we started to get hemofiltration, and up to about 2018, we did CVVH with heparin, and we had a filter life of 9 hours. Then that's, and then we started to introduce citrate anticoagulation very late. It was well in the guidelines long before that, and our filter life went up to 34 hours. And you'll notice we reduced our dose in response to papers that we should have reduced it from years before. We then went to hemodialysis, and we increased our filter life to 56 hours. And my sort of evolution in aircraft here is, this is my favorite aircraft. I don't know why AI has given it 3 engines. It's only got 2. But that kept crashing, even though it was changed the world of jet travel. It kept crashing. This really did change the world of travel, and just allowed you to go long haul. This really did change travel again, because it went from 4 engines to 2 engines and allowed you to fly basically around the world and go for much, much further distances on 2 engines. And then in the future, we've got this plane that's actually going to take us from Sydney to London and Sydney to New York without stopping. So it looks the same, but there are subtle differences which make it even better. And I think that's where we've got to, because you can see we've changed our dosing, but now we've gone to dynamic dosing. And as you can see here, our outcome measure changed. Our outcome measure at the start was filter life. The nurses were getting fed up having to change the circuit every shift. Then they got really excited because they could go a whole shift and in fact come back the next day and still not necessarily have to change the circuit. Now they've forgotten how to change circuits, and we often only use one set for one treatment. And so you can see, but now we've changed our outcome measure again. So we've got filter life sorted now. So now we're thinking about what else can we do? And I think that's where the dynamic dosing idea really came to fruition, because we were like, well, we've sorted this bit. What's next to do? And I think that's the evolution. And the evidence was beginning to tell us that there are different outcomes and different doses of therapy for different outcomes. So what are the benefits of dynamic dosing? Why did we think this would be a good idea? Well, I think we wanted to get more rapid stabilization for sicker patients. And we thought that if you could correct some of that severe biochemistry quicker, they might do better. We want to individualize care as patients respond to treatments. We thought that we could see no benefit in running high volume renal replacement therapy once we have stabilized their biochemistry. We wanted to minimize complications of RRT, so we didn't want hypophosphatemia, and that's something we still struggle with, and I'm sure everybody does. And we're becoming more and more aware of potential damage that renal replacement therapy can do. And we want to reduce waste and cost, and I think this is real. We actually have a nurse who is a sustainability champion on our ICU, and I think this is really, really important. We need to think carefully about the therapies we're doing and their impact on the environment and the waste and the cost. We are not an unlimited resource, and we're a wealthy country. So we've got these prescription controls, right? Okay, so what prescription controls did we then look at to think, well, what might we be able to do that could help with our dynamic dosing? And we basically look at these 4. That's where we are at the minute, okay? So, I mean, you can argue that we do have a UF profile in the fact that if you're early on in your illness, we tend to just resuscitate as necessary and then de-resuscitate afterwards. So I suppose we've got that inbuilt into our own philosophy. But we can control the blood flow rate, the effluent rate. We've chosen dialysis diffusion because we feel that the evidence suggests that gives you a longer filter life. That's how we got even to making these decisions. We want to look at the dialysate and the replacement composition more, and we have a lower bicarbonate fluid so that we can use citrate to act as our acid-base management. So we begin to pull these things together, and we want continuous dose delivery, and that's why we chose citrate in the first place, because we feel that interrupted therapy probably isn't good for you. So we've begun to manipulate these prescription controls, and actually it doesn't seem too complicated when you break it down like that. How do we do it? So we do CVVHD with citrate anticoagulation, and this is our circuit. We run our citrate concentration at 4 millimoles per litre. We do not regularly check our post-filter ionized calcium level, but we have done some studies and shown it pretty much sits between 0.3 and 0.5. When we increase the blood flow, in order to maintain the citrate concentration, the citrate volume goes up. Okay, if the citrate volume goes up, you produce more bicarbonate and your pH increases. So you've got a lever. So your lever there is blood flow. If you increase your dialysate, you're going to increase clearance because you increase your dose. Okay. We're actually also going to dialyze out calcium citrate complexes. Okay, so if you're dialyzing out calcium citrate complexes, actually you have more clearance, but you reduce the amount of bicarb and your pH decreases. So this also gives you a lever to manage alkalosis. Okay, that is not without its controversy, and we'll come to that in a second. But this is how we built this protocol. Obviously, you need to give some additional calcium, and you need to give more additional calcium if you have more clearance because you clear more calcium. But we have a protocol that guides that. And this is what our protocol looks like. And this is what we give to our nursing staff. So, you know, and you might look at this and go, this looks pretty complicated. But it's actually fairly straightforward. You just take the pH, you look at the potassium, and you go down your grid, and you choose your blood flow and you choose your dialysate flow. We've split it into two groups for greater than 65 and less than 65 kilograms. And I'll kind of explain why in a minute. So we've got these, essentially, we've got these two lookup tables. Okay. What you can see here is that as you increase the blood flow or decrease the blood flow, you can manage the pH. So as the pH goes up, you can decrease the blood flow and decrease the amount of citrate you give. If your potassium is high, you can do more clearance, and as it gets back to normal, you can do less clearance. Okay, we manipulate the dialysate flow rate to manage potassium and also bicarbonate. But there's a real question here. Are we now in a position where actually our protocol could potentially cause harm? And I think that's a new question that we have begun to think about only in the last 18 months to 2 years, because we increase your dose in order to reduce the amount of citrate going into the body and therefore manage alkalosis. But could that in itself potentially cause harm? So we want to do things differently. So we want to improve and we want to build on this. Okay. I think the reason we did that to start with, and the reason that we have two different sets of protocol for depending on your weight, and the reason that we were pretty cautious was because we had to convince our medical and nursing colleagues that this was going to be okay. It was quite a step from the norm, in inverted commas, when we brought this on board. And it was also just around the time of COVID. As COVID was coming out, we suddenly decided we wanted to do something different. And our nursing staff, as you might imagine, fancied a break, as did a lot of the doctors, to be fair. And we said, no, but we think this is a good thing. And we'd learned quite a lot from COVID about doing high volume, because we did sort of intermittent renal replacement therapy. We were a massive COVID centre. At one point, we had 56 people on renal replacement therapy, 12 of which were having intermittent dialysis in a special unit that we built in our COVID ICU. We had 156 on ventilators on our peak day. And we had 35 CRRT machines that we'd gathered from everywhere. And so we'd learned a lot about dose changes. We'd learned a lot about prescription changes. We'd also learned, though the nurses hadn't realized it, that we could change things. We could change things on the run, and they were very, very good at dealing with it. But they were worried and they were concerned. We were also constrained by the safe dose range at the time, which didn't have very, very low dosing. My colleague, John Prowell, who I work very closely with, who's a reader in intensive care medicine at the university, and much more knowledgeable on these kind of things than me, to be honest. But, you know, him and I had both sort of felt that we could go lower, but we didn't want to introduce too many things at one time. And we weren't sure the protocol would be followed, though we secretly believed that the nurses would be absolutely fine because we'd seen how they'd adapted during COVID. And I think it was a real good opportunity to bring something in. So we did dynamic dosing for continuous renal replacement therapy. We did a service evaluation, and we looked at the effectiveness of titrating dose to biochemistry. And we found some really helpful things that gives us a step to go further. We found that this was safe. The dose over time was comparable to the fixed dose, and that meant that our colleagues were comfortable. Okay, we found that our nurses were better at following a more complex protocol than a simple protocol. And you think, why is that? I think that's because you empowered them and you gave them something. You gave them an objective about treating therapy. You introduced them to individualization of therapy, and you got absolute complete buy-in. I think it helped that our CRRT systems were running on an average of 56 hours. But I mean, and that's censored for reasons other than clotting. But I mean, we've got, so they could be involved in understanding the therapy rather than just changing the machine, right? And that is dialysis and citrate put together. Our filter lifespan was comparable, so we weren't losing anything by fiddling with the dose. We did show a quicker correction of chemistry, and we showed a reduced instance of alkalosis, particularly in the citrate cohort. And I think that's because we're able to manage that. And we always said, and we said back then, that there's a detailed study to be done. But things have moved forward even more. And actually, the question has got more interesting. We want to improve individualization. And in fact, we haven't been asleep for 2 years. We've been doing something in the background. We want to widen the dose range option. We want to have a much more sophisticated dosing algorithm, which we're trying to build at the moment. We want to look at urea, pH. Is that the right measure of acid-base balance? Should it be bicarbonate? Should it be base excess? Obviously, potassium is key. What are the effects of swings in sodium? Our albumin levels, they drop a lot. Hematocrits, we have we're also a neurotrauma and a head injury unit. So we have lots and lots of sodium abnormalities that sometimes need renal replacement therapy. We would like dialysates that help lower the total doses, and we want solutions with lower citrate concentrations to help reduce our overall dose. We have done some work on trying to reduce the citrate concentration, but unfortunately it's not likely to be viable. My colleague John, who I mentioned, is sitting on the database and is yet to write it up. I did hassle him before today to say, can you send me the data? And he goes, I haven't done it yet. But that will show us that actually, if we do reduce the citrate concentration, the ionized calciums do go up. So we're a bit anxious about doing that. So we need another way. I think, we are mindful of the increased dose to control alkalosis. And is this time for an RCT? And I was briefly chatting to Louis about it beforehand. We've got lots of RCTs that are still chasing, I think, a fixed regimen without acknowledging, although we've written, and it's in the literature, that our outcome measures change, and we've written a lot about different outcome measures. We haven't put the two together and gone, hang on, our outcome measures change during treatment. And can we do a trial which follows that pattern and demonstrates that we'll have better outcomes, which will be variable during a course of therapy. It's challenging, but complex problems are not impossible. They're just complex. And I think this is one of them. And I think that we are really going to try and push and head towards this. So what's my overall conclusion? To give us a bit of time for questions if you have any. So I think CRRT can be oversimplified, okay, and it can be oversimplified incorrectly, but not because people are doing things badly on purpose, but because it sometimes you've got to think processes through and you forget what your objectives are. But I'm also really acutely aware that we don't want to make it overcomplicated and realize we haven't got any benefit, which is why I think a trial is really important. If someone was to show me that this didn't really change anything, then that would also be useful information. We're adding more complexity to our dosing algorithm. Are we in danger of overthinking it? And my other conclusion is that you must go back to your objective and review it. I think renal replacement therapy should be dynamic. You should respond to your patient, and it will mean that your objective changes. And I don't think that's a bad thing. I also think that keeps you sharp. We see our patients at least twice a day as a consultant, and our residents and nurses are there all the time, and our nurses are at the end of the bed. They have autonomy, certainly in the UK, if there's people here not from the UK, and we're lucky with that, I think, and they thrive on it. They've thrived on a more complicated and more interactive protocol. I think less can definitely be more, and I'm really interested in the idea that too much therapy can be harmful, but I also don't think that we should dismiss high volume therapy either. More is not always less, and I think we've got to find the balance. We've got to find how to transition. Finally, look, there are a number of protocols which can deliver dynamic dosing. Okay, you're welcome to use ours. I mean, we share it with anyone who wants it. Okay, but we're continuing to work on improve it. You don't have to use our system. You don't have to use dialysis, and you can do it with in many different ways. You can make your own protocol up, But I think there is future than this, and I think there is more to do. I am going to steal your time for 2 more slides, though, because I have one final plea, and this is something that I go on and on about. And and for the people who are listening, don't ignore the need for good access. All of this is entirely pointless if you don't have good. I've just seen Louis laugh. I suspect you've probably heard me say this before. We published something a few years back when we were doing CBVHF and citrate. And I can't express more the absolute importance of having the tip of your dialysis catheter in a good position, because we independently showed that regardless of anything else you do, if your access is rubbish, nothing else matters. That is the determinant of how your therapy goes. So but I say overcomplicate it. Let's make this bit really simple. Before you do anything with your protocol, before you do anything about individualization, please have good access. And I think that's my last little bit of talk. So I'll leave you on this conclusion, and I'll welcome any thoughts or questions. I might stop sharing my slides so that you can see me a bit better. But I hope that gives you an understanding of why I think this is a good idea, how we got here and how that idea developed, and what I think that we could do in the future to understand this a bit better.
Well, Chris, that was really excellent. I really enjoyed it. The only reason I was laughing was it had occurred to me about 5 minutes before that this is the first lecture I've heard you give in about 10 years that isn't about venous access. And then suddenly it popped up. I
can't get away from it.
I'm glad you didn't let the team down. Now, it's Gemma, do we know, have we got questions in the chat?
We don't have anything from the chat yet. So please, anybody or everybody on the call, please do pop any questions for Chris or Louis. And we also have Michael joining us now as well. But I'll let you guys have a quick chat first, and I shall interrupt if we get any questions.
Right, because there must be a zillion questions. I mean, the first thing I'll say is a statement, right, Chris? I've always found, we quite happily change our ventilation strategies depending on what our patient needs, right? And yet it's a complete anathema to some people to change the renal replacement therapy prescription. It just chunters along and does something that probably people don't understand as much about as they should. So I've always used a dynamic protocol, but in a slightly different way, really. I've just based it on my effluent rate and the dialysis dose I use. So, initially I'll give a higher dose and then I'll run down to 25. One of the things you didn't touch on, actually Michael's here, so what I'll do is, actually Michael's phone's just gone, so I won't do that, is the theory, Mink Chowler's wacky theory about permissive azotemia and recovery. What do you think about that? Because that might be, if we assume there's some truth in it, right? And you've got to remember the Keserai is German for heresy, so that's the name of that trial. But if we assume there's some truth in it, what do you think?
So I don't have a problem with waiting. And I don't have a problem with waiting to see what happens. And I think the French have done quite a lot of work on trying to wait a really long time and allowing the kidneys just to see what happens. And an awful lot of people recovered renal function without getting renal replacement therapy. So the idea that you can wait, I think, is fair. What I found is that it's hard for everybody to do that. And in critical care, what you do is you hand over patients a lot. You look after them for 4 days. Well, we do sets of 4 and 3 because the intensity is so great. And this is a long-term strategy that is harder for everybody. And for people who are not necessarily super familiar with renal replacement therapy, or perhaps not as confident as people who've trained in nephrology like you and I, Louis and Mink, that you can do this. It's also interesting. we have a lot of people with head injuries, and we've got a lot of trauma cases, and high urea is felt to be a significant factor in altered states of consciousness and delirium. And we have a massive delirium problem, okay? And I think when you're looking around the room and you're dealing with heavy sedation, brain injury, polytrauma, even severe sepsis, and then you're allowing the ureas to climb 35, 40, 45, and yeah, sure, the potassium might be okay, and now you can give medications that excrete potassium through the gut. It's clouding the rest of your clinical judgment. And I'm completely sympathetic to the fact that's going, well, hang on, there's a modifiable endpoint here, modifiable measure here that we could change that might change the way that we're viewing our patients. So I think it's quite hard to do. But I do think that you can start too early. And we do ask that there is a real target. I also think that fluid status is an absolute indication to do RRT. If you've got a normal, in inverted commas, urea and creatinine, whatever that is in critically ill patients, and but you are not managing your salt water balance, then you have acute kidney injury. And in order to improve and in order to get better, you may need renal replacement therapy to support that recovery. So sure, you can definitely leave people for a long time. If you leave the kidney alone, will it recover? Will it recover better? Do we think that there is dialytrauma associated with RRT? Well, I think Emily suggests that there is, and I think that might well be true. And so there is a definite benefit about trying to leave people alone for a long time. But on the other hand, I think there are so many confounding factors that probably prevent that from being standard therapy. Is that a reasonable answer?
Yeah, but the other point that Mink made, which is interesting, is that pursuit of nirvana in terms of when we're on the machine, in terms of urea and other measured molecules, might actually be harming protective and repair mechanisms. So aiming for a urea of, let's say, 15 to 20, the kidney may prefer. That being a marker of, So his argument is that, permissive azotemia reflects a milieu that the kidney prefers to heal in or repair than normal values. I mean, it's an interesting concept. It's been known for a long time in animal studies using partial nephrectomies and whatever.
So I think that sits nicely with the idea that with a fixed dose protocol, you over dialyze people who are in recovery phase. And we don't need, and so I completely agree with that as well. And I think if you turn people down to 13 mils per kilo per hour once their acid base is restored and their potassium is safe, then you can focus on fluid removal without over dialyzing them or over filtering them, whichever method you choose. And you would also save a packet and probably a whole load of blood vessels on intravenous phosphate infusions, which I think is another sort of marker of harm, which I think was shown again right back in 2009, isn't it? With the Australia. So I think, so yes, absolutely. Which is again another thing about actually we can do low dose safely once we've got out of the acute phase. So Michael, I think you had a question.
Yeah, I had a question, Chris. I really enjoyed your talks. Thanks a lot. My question was about your individualization of dosing. You had a very nice concept on the various aspects, acid base, potassium, and then the individualization about the uremia aspect. So I'm always suffering with the question, so how do we know that at which dose we are correctly treating uremic toxins and the uremia aspect as you explained? So what is the target molecule we should monitor for that? Or do we have anyone? Or what is your personal opinion?
Right. So my personal opinion is undecided. I think it changes. I think my target molecule is usually potassium, because it's usually potassium that makes you start, or that's what gets people the most upset. So once you've controlled your potassium, go back to what Louis just been talking about, urea is less important, but urea is the unifying molecule that helps us match dose, okay, because it was the first molecule that we could measure, right? And so urea is ever present. Also, urea, some of the work that I did that Louis marked for my PhD was about actually urea is probably not an unreasonable measure of overall renal function in critically ill patients, despite all the effects on urea in terms of, if there's GI blood, what the hydration status is, what the feed is. And in fact, one of my other colleagues, the Professor Zudin Pusheri, who I work with, is actually doing a study on feeding at the moment. And one of our questions to him is that he's going to affect, if his feeding and muscle wasting work affects urea, does that become an obsolete measure of renal function in critically ill patients because of the metabolic changes that you're doing through feed? And that's really, really important. And then again, back to the other point of having lots of people with head injury and then delirium, and then does high urea affect the neurological examination and your neurological assessment? Does urea come back into play? I think our answer to your question is that I think you have to look at your problem, think about what your objective is, what it is I'm trying to achieve, and then focus on that objective until you've achieved that objective, and then reassess. So if your urea is high and you've got someone with neurological disturbance, I need to clear the urea. But if they are on a special feed and they're trying to reduce muscle wasting and the urea is now not an indication of renal function, actually, am I just targeting potassium, or am I just targeting acid-base correction? And is that pH, should that be bicarbonate, should that be base excess? And I think the whole point is that the question will change, and we need to move away from urea as a direct measure. But on the other hand, urea is what we have that compares it to everything else.
So I'm going to jump in if that's all right. Thank you. Thank you, Chris. So we've got a bunch of comments and questions. So a lot of people enjoyed your talk, which is, not surprising. And first question actually comes from Bearbroom McNicholas, who is the third speaker in our series. But yeah, a lot of these questions are really nice and practical, and this is a great one to start with. So fantastic talk, Chris. How do you think we should manage dynamic dosing in patients who you want to liberate from 24 hours of CRRT to facilitate physio, rehab, all of that sort of thing, that are not able for intermittent, or you don't have the facility for intermittent in your unit?
Yes, that is not an uncommon question, and it's got even more. Thanks for coming, Barbara. It's nice to hear you, and please go listen to her talk, because I know it'll be great as well. In a few weeks' time, I can't see you on the screen, but I know you're there somewhere. Right. So, with the improvement in filter lifespan, we found ourselves patients stuck on CRRT who probably could stop. And we have to learn to get better at stopping CRRT per se, regardless of for whatever reason. But I mean, I think, if you've got somebody who's on a machine for 96 hours because your anticoagulation allows you to do that, and they didn't need to be on it for the last 24 hours, you might have done harm, and you've wasted a whole load of resource. So we should be good at stopping. We should be better. We should be better at stopping. If you talk about physio, there is a paper somewhere, and I've got it, I'll share it with you, that clearly states that CRRT is not a barrier to physiotherapy and rehabilitation. And I show it to our physios all the time. However, I know what you're going to say is that if you've got a line in the groin, it's completely impossible to do anything. It will just stop. And it's just harder and it's more difficult. And the fact is, if you're getting people up and doing physio with them, do they actually need to have renal replacement therapy? So if you then get into the situation where you do intermittent continuous renal replacement therapy, an oxymoron, I know, but you can't do 4 hours of intermittent hemodialysis, but you do want to give people time off filter of the CRRT machine because they don't need renal replacement therapy, can you then have intermittent high dose therapy? And we did that in COVID, and we had this thing called PERT, which was sort of partial intermittent renal replacement therapy. I can't remember whatever it was, where we gave high dose for 12 hours and then gave the machine to someone else and did high dose for 12 hours, and then gave the machine back to that other person, did high dose for 12 hours. So I think then what you're actually asking is you're asking for a different protocol for maintenance therapy when there's no intermittent hemodialysis facility available. We don't have intermittent hemodialysis on our standard ICU. We try and get patients to a point, especially if they're tracheostomy weaning or stuff like that, we can take them with a nurse to our acute dialysis unit, but that's quite rare. And what we do is we actively stop and actively restart. And actually we use our dynamic dosing protocol when we restart 24, 48 hours later, and just follow that based on the chemistry. So, but I think you can do I think you could do various different things. I hope that kind of answers your question. But we need to get better at stopping, I think is.
That's good.
Yeah,
Next
and
question.
you're kind of
Sorry,
out of the dynamic dosing window then by the time you're in the
Yeah, you are.
recovery
I think
phase.
you are as well.
So it's almost not irrelevant, but it's less. It's more of a technical issue as to how you do it rather than what dose you're delivering. Okay.
So next up.
Yeah, go on.
Sorry, Kyle. No. So basically, this again, it's another very topical point, which does tie into dose. So thanks for the elegant lecture. In extreme body weight considerations, which body weight? So assuming I think we're talking about obese patients here, which body weight do you prefer to use? Actual, adjusted, or ideal?
Yeah. So ever since I became a consultant, our unit has stuck with ideal body weight, and we haven't changed that. And we do that just by measuring the height and doing an algorithm. There's a whole load of debate, and what happens to medications, volumes of distribution, how you work it all out. And we took a practical and simple measure, and we just stick with ideal body weight, and that's where we're going to stay. And I think in a dynamic dosing protocol, will probably take the weight away in some senses. I mean, like you got to use the ideal body weight and go, this is your ideal body weight, this is what we're doing per weight. But actually what we want to try and do is we want to try and improve the algorithm that goes, what's our objectives? And our objectives are to improve the chemistry or improve the acid base balance. And what do we need to do to try and do that? And if it's not working, you'll change it and you'll go up a grade and you'll go up a grade. And everything at the minute is dose related to mils per kilo per hour, which is ideal body weight for us. But the whole point is, I think we're trying to just give as much as is needed to correct the outcome measure, which will be attached to a weight, but that will be less meaningful. I hope that, if you see what I mean. I think because it's, we're not going to start comparing mils per kilo per hour. We're going to start measuring the clearance of the correction of our outcome measure. So
I think we should all use ideal body weight.
Yeah, I mean,
it would make the world a much simpler place. We don't measure height, Chris. We use ulnar radial measurement, which is really easy and very accurate. And some of the companies,
I don't know why the
companies give you paper tape measures to use. And
we have got, I know the TED stocking measures, isn't it? I don't know. Our nurses do whatever they do, and they're happy doing it, and I'm grateful for all the work that they do. So I'm probably not. I mean,
don't rock that.
So this is what they do. Yeah.
There's some other questions in the chat, Gemma. I like the one about Dialytrauma, so I'm going to ask that. All right.
Yeah, is this the overdialysis? Yeah.
Do you think adaptive need for dialysis leads to more dialytrauma and dependence on RRT? That's an interesting.
So I'm going to completely back this one away and say you need to go into the website and listen to Dr. Emily C's talk, because it's really good, and B, and it covers that. She tries to sort of understand dialytrauma and intermittent hemodialysis, which I think is a bit better understood, and relate that to what potentially the harms could be in CRRT. And I don't want to. I think you should go listen to her. Sorry, I'm not going to answer it. I'm going to make you go back and listen to her talk. Is that all right?
So I'm going to answer it.
Okay.
Seeing I did one of the first papers on dialytrauma in acute kidney injury. So I think that probably less. There's a thing, right? I think that you've probably got less dialytrauma because you're correcting, if you're looking at cardiac performance, you're probably correcting stuff early, which will lead to improved cardiac performance, and then you'll have less global strain longer on in treatment. So I would say that if you do an adaptive process, you may end up with less. Put my neck on that particular block. Right, Gemma?
So I have a long one from Italian intensivist, so I'll come back to that in just a second. But we've got one of your colleagues from one of the other trusts in the UK that's a big fan of your protocols. But basically, you touched on this a little bit, Chris, actually, about mesenterias. And can you say something about managing sodium changes when you're starting RRT in a hyponatremic patient? And do you modify or how do you modify or mitigate changes along the way?
Yeah. We've got modifications of this protocol for high and low sodiums. And they're not dynamic in the same way because our outcome measure becomes sodium. So back to our point of like your outcome measure changes, and it's there's loads and loads of sodium in citrate, and so in the hyponatremic patients, it's quite hard, and we have to give a lot of basically 5% dextrose, and we give that IV in order to try and make sure that we don't raise the sodium too quickly. We don't put water into the dialysate bags. I know people have done that, and I've worked in units where they've done that, and they've done that successfully, but we decided that that's not what we were going to do, and so we just give 5% dextrose as a water substitute, effectively IV, and we've got a protocol that does that, but it's slightly different, and it's with a fixed blood flow rate, so that we're not fiddling with the citrate concentration. We're not fiddling with the amount of citrate and the amount of sodium we're giving. So you might not get a good clearance of other toxins, but the most important outcome measure until you get to about 130 millimoles per litre is the sodium. So it's a different protocol. My utopia is that we have a web page or an app or something where you type in various variables which include the sodium, and it will tell you what flow rate to put the blood flow and what flow rate to put the dialysate, and it will have incorporated all of those things and whether we need to adjust for sodium or not. And also we want to find different solutions that have less sodium in them for that. In hypernatremia, it's a lot easier because we've got very concentrated saline solutions that you can use to just slowly run down as the sodium falls, and we find that a lot, and also because there's loads of sodium in citrate, so it's a lot easier to do. So we find hypernatremia, and we see a lot of hypernatremia again because a lot of people get hypertonic saline head injuries and trauma and things like that. So we probably see more hypernatremia than I think the normal population, but there's loads and loads of hyponatremia, and I think we go onto the protocol when it hits 125. Which some people might say is a bit brave, but I think we're happy with 125. So when you get to sodium 125 millimoles per litre, then we start the low sodium protocols.
Cool.
Okay.
Thank you. So this is more pointing towards kind of the skills of you and your team as prescribers. So we have an Italian intensivist who's worked in ICUs where CRRT is managed by nephrologists entirely. There's few standardized protocols, or in ICUs where they're kind of left to their own devices. They then led to adjusting their dialysis parameters 2 or 3 times a day, a bit like they do with their ventilation. So this concept is really new, and obviously based on evidence, which is great. So what was the specialty and the skills of the prescribers in the study that you showed, and how long do you think we will take to get to the standardization of targets?
So the way that the ICUs in the UK work is that we have an intensive care consultant who is kind of the secondary consultant. So we manage everything that goes on in ICU, but they're admitted under somebody else. So if you're admitted for aortic surgery, you'll be admitted under the vascular surgeon. But when you're in intensive care, we lead the treatment. And intensivists, our intensive care consultant cohort ranges from people who've purely trained in intensive care to people who've done anaesthetics. There's 2 of us are nephrologists. We've got a respiratory physician. We've got 2 acute medics. And so there's a broad and there's a couple of ED physicians as well. So there's a broad range of people. CRRT is supposed to be taught in the curriculum as you are doing your intensive care training as a what we call a resident doctor, so the grades below consultant. But we know that teaching is patchy, and we know that the level of understanding is very varied. And in fact, the level of understanding about CRRT is very varied across the world. And there's a recent paper which I know Marlies Osterman, who's a colleague and friend of mine and Louise, and Barbara's on that paper as well. She helped, which is about a survey of how people use CRRT and why they do things for and what they think the reasons are. And you can see that there's quite a lot of varying opinion about what certain things do in certain areas. So there's a lot to learn. Our prescribers are those resident doctors. They're the people that are training in intensive care and with us to learn to be intensivists, but also they are people on rotation from internal medicine rotations and from respiratory and from anesthesia and from ED. So there are people who are not learning to be specialists. The nurses drive the protocol. So our nurses, it will be prescribed, the solutes and solutions that you need will be prescribed, and then the nurses will take out the protocol and they will follow the protocol based on the chemistry. So it's our bedside nurses that really set it up and start the machine. Okay, and we're a big ICU. Obviously, we have what we call a link nurse on every shift, but you've got to remember we've got 40 plus nurses on every shift. So one of those is always a sort of a more specialist link nurse that we train. We do teaching sessions every year. Our practice development nurses go through them, and they have intimate knowledge of our system and our protocol, and they can help troubleshoot and direct. That's easy for us because we're big and we've got this, we've got the volume of patients. It's harder in smaller units. However, I don't think it's impossible. And I think what we found was, like back to my point from the paper, is that complex protocols are well received by nursing staff of all grades. So even if you're brand new, they found it helpful, they found it interactive, and they responded because they were given some autonomy. You're not allowed to change everything all the time. If you've got to modify, so you've got to take blood gases every 2 hours because of the calcium, unless it becomes very stable. But you're only allowed to modify the dosage of dialysis or the blood flow rate every 6 hours. So we sort of put some brakes on overcorrection, and we found that works really, really well. I think we are a bit unique. The nephrologists don't know much about CRRT, and I go and talk to their trainees about what CRRT is so that they have knowledge when they come to the ICU, but it's not a nephrology problem. And acute kidney injury is not really a nephrology problem unless it needs intermittent hemodialysis. It's a medicine problem, it's an intensive care problem, it's a surgery problem, it's a marker of illness. And so, I think that in itself is one thing, and then the CRRT is managed by us in intensive care. I think we're also lucky, there's 2 of us that are trained in nephrology, the consultants in our intensive care unit, and I accept that we are fortunate for that, but it helps us to do the stuff that we're doing. Hopefully we can support other people who don't have that, aren't fortunate enough to have that skill set, I think.
Perfect. So we are we're 3 minutes over time. So
Right, okay.
Let me just wrap up a couple of things. So one, based on the last sentence you said there, Chris, there's a couple of requests to share your protocol. I don't know how the easiest way to do that, maybe via the ISCCN or similar.
I'll ask Louis how we can just put it on a SharePoint or something. I don't know.
Well, we may be able to put it's one of the things that the society is aiming for, which is a repository of protocols.
Yeah,
and
I mean,
let's make the London one the first. What do you think, Michael?
Yeah, absolutely. That's I think that's one of our agenda. And if you would like to share your protocol with our society, we put it on the website on repositories. So we will open up this. If this is okay for you.
We have time for one more quick question. There's one last there was a couple of questions, but this one's been sitting for a while. How do you manage the anti-inflammatory role of CRRT with a lower dose? And in other words, how do you choose diffusion versus convection?
Yeah, that's a whole nother lecture.
Yeah, I thought so.
It's a whole
that's number 4
lecture
in the series.
Yeah, exactly.
Yeah, number 4, which we haven't done yet. So I am not convinced that there is a mortality difference between modes. Okay, and I am not completely convinced that filtration and its potential to remove bigger molecules improves outcome. So we chose dialysis because dialysis improves filter lifespan, and it's as simple as that. I am open to suggestion, and I'm open to people showing me that diafiltration or filtration offers an outcome measure improvement that is useful. But I haven't yet been convinced that that's why we do it, and we chose filter lifespan as our outcome measure. We've also talked a lot about absorption and running absorption filters in parallel and whether this reduces cytokines, things like that. Again, we as a unit, and I spend a lot of time talking with John Prowell about this because obviously we share an office, but we're yet to get involved in that and to think that and to see a reason that we would want to change what we're doing at the moment. But that does not mean that we are not open to suggestion. And I think that we wanted to get decent filter lifespan. We've got decent filter lifespan, and we're beginning to focus on dynamic dosing protocol. My other argument, if there was an anti-inflammatory aspect or a pro-inflammatory aspect of RRT, higher dose at the beginning, lower dose later, potentially covers both of those problems if you think it's one or the other. So this might be a solution for that if we can show that that's a thing that needs modifying. So a bit of a wishy-washy answer, but we chose dialysis because it gave us the longest filter life, and it is as simple as that.
Yeah. Right. Okay. Well, I think unfortunately I'm going to have to call time on this. So it's been, Chris, that was terrific, and
Thanks,
by
Lou.
the engagement from the audience, that shows that people generally really enjoyed it. It's an interesting concept. I think you delivered it really brilliantly. So thanks for that.
Thank you.
And thanks to and it's good to see you again. And thanks to our sponsors, Nordia, who've been terrific in helping us set up this series. And as I said to you, we'd like to get some more members. So join the ISCCN. It does have lots of benefits. Not least, it's not very expensive. And if you publish in blood purification, you get one publication free a year. So you can actually save yourself a lot of money. Right. And as a speciality, we're growing and we want to maintain that identity, really. Okay, I think that's, unless there's anything else, Gemma or Michael, you want to add?
I was just going to very quickly share, just to finish off, just to trailer for that final talk. Am I still on mute, actually?
No.
So yeah, we've got the final session.
Yeah.
Perfect. So Bearman Nicholas will be talking through CRRT, sustainable practice and prescribing. So yeah, really nice kind of bookend to the sessions and kind of leading on from what Chris has touched on. So that's on May 26th, and you can register for that now.
Excellent.
I think that's a really important topic. A really important topic.
Yeah, brilliant. So, and Michael will be chairing that, I think. So
yes.
Thanks everyone, and we'll see you on the 26th of May.
Perfect. Thanks, Chris.
Thank you very much. Bye bye. Bye bye.
Bye, Chris.